Hello and welcome to today's session. In this video, we'll be covering renal failure, kidney failure for that matter. And for this one, we'll be looking at acute renal failure versus chronic renal failure. Starting with the acute renal failure, we'll be looking at the causes of acute renal failure, look at the stages of acute renal failure and attempt to give management. Equally, we'll look at the chronic renal failure, look at the stages of renal failure or the types of categories used to classify, criteria used to classify a chronic renal failure, stages of renal failure, risk factors, incidents, and finally the treatment of chronic renal failure. In the end of the video, we'll be attempting to look at the differences between acute renal failure and chronic renal failure. Welcome to the presentation, okay? Great. Starting with acute kidney injury, acute renal failure. We're saying that this is sudden, okay, sudden in onset, sudden decrease in renal or kidney function, which normally leads to build-up of waste fluids and electrolyte imbalance. We're saying that this one may be reversible, okay, as opposed to a chronic renal failure, which we'll be looking at some point where it's normally irreversible. Acute kidney injury is also termed as acute renal failure. We have three causes of this condition. Number one, we have pre-renal problems, renal causes, and post-renal problems. Starting with pre-renal problems on my right, I'm saying that pre-renal problems or causes affects the renal perfusion, decreasing its function. So decreased blood flow to the kidneys leads to less filtration, which consequently deprives the kidney of essential nutrients. So persistent impairment, normally leads to intrarenal injury. Okay, so pre-renal causes are related to cardiac issues, damage to myocardial infarction, which eventually decrease the perfusion, to the kidneys. Okay. Pre-renal problems, we are saying that all these lead to decreased cardiac output. And when you have decreased cardiac output, you have less perfusion. Other factors that can lead to decreased cardiac output include bleeding, which could be internally, especially for those guys with GIT disturbances like PUD that can result in internal bleeding, or externally, like the PPH, the accidents, injuries that can lead to external loss of blood. So it's important to note that dehydration also contributes to pre-renal problems as it normally leads to hypovolemia, meaning less blood is being supplied to the kidney. Burns also contribute to hypovolemia, and they use the same mechanism by causing dehydration. When there is that fluid shift, thus less blood is supplied to the renal organs. Number two cause of acute renal problems is intrarenal causes, and intra means in. So it involves damage to the nephrons, okay? Remember, the nephrons are the function units of the kidneys. So when this happens, it results into decreased ability to filter blood, remove wastes, and excessive water. Also, there's decreased ability to maintain electrolyte levels, especially the most common one being the potassium, sodium, and calcium. One of the major causes of the intrarenal problems will include nephrotoxic drugs like the NSAIDs, antibiotics, especially the aminoglycosides, chemotherapeutic drugs, or contrast used during testing, all contribute to the damage of the nephrons, decreasing the ability to filter and perform other functions. We have other serious infections like glomerulonephritis, which we'll be looking at some point. So a link will be coming up. You can be able to refer and review the glomerulonephritis. Also, injury to the kidneys can also contribute to intrarenal causes of acute kidney injury. The third cause is the post-renal causes of acute renal failure, and this one leads to blockage in urinary tract after kidney to the urethra. Okay, so this prevents urine draining out of the system. So any cause that is going to block, okay, the draining of urine out of the system will be the post-renal. Okay, post-renal. Okay, it is after the kidney. Post-renal, after the kidney. Very good. So this leads to increased pressure in the kidneys and wastes, which decreases renal function. Okay, so the increased pressure in the kidney normally leads to waste accumulation. Yeah, so and as a result, renal function is decreased. Several causes are involved in this one, in post-renal causes. Examples could be renal calculi, enlarged prostate gland, neuro injuries, stroke, where the bladder does not empty properly. So as a result, we start having post-renal problems that eventually contribute to acute renal problem. So guys, on my right is a try to summarize what you really need to know. We started with pre-renal. This one is marked decrease in renal blood flow. So there is marked decrease in renal blood flow. So less blood gets to the kidney for filtration and for removal of these other wastes, water, and maintaining other electrolytes. From there, we go to another cause could be in the intrinsic, in the kidney itself. So there is damage to structures within the kidney, okay, within the kidney itself. Then we have the last causes that normally target the post kidney, after the kidney. Yeah, so we have post renal. So we are saying obstruction of urine outflow from the kidney. So guys, this is the summary of the pre-renal, intrinsic, and post-renal causes of acute kidney injury. So guys, we need to also to know the characteristics of urine. Does the normal urine appear? In terms of color, we are saying it's normally pale yellow to deep amber. And we are saying that the yellow color is normally due to the euchrome, a pigment that results from body's destruction of the hemoglobin, guys. Also, a link will be coming up on the metabolism of bile, and you can easily look at it so that you understand better how the yellow color for urine normally comes about. In terms of odor, we are saying it is odorless. Guys, I've heard of urinary tract infection patients. Our patients with the diabetes mellitus reporting that their urine smells sweet. Yeah, I hope we get that. In terms of volume, how much volume is an adult expected to excrete? Yeah, in 24 hours. Of course, we say intake is usually 2 to 3 liters. Yeah, but outlet, which is the urine, is about 1 to 2 liters. Okay, and that explains how the urine output and input is. Turgidity, we're saying that urine is clear to very slightly cloudy. Okay, cloudy urine, we are going to suspect an infection, and therefore we need to get to see what is the cause in that matter. In terms of pH, the urine pH ranges from 4.5 to 8.0. Remember, an alkaline environment will encourage more bacteria, okay, to grow, leading to an infection. Okay, we prefer acidic so that it can at least be able to take care of those microbes. Specific gravity, and you're saying it ranges from 1.003 to 1.032. We are saying that high specific gravity indicates there is dehydration and probably the need for more rehydration or rehydrating the patient. Okay, osmolarity ranges from 40 to 1350. Okay, urobilinogen will range from 0.2 to 1.0. White blood cells, guys, we are looking at the high power field of microscope. Okay, 0 to 2. Okay, leukocyte exterase should be none. Protein, we either need to be having none or stress. This will be very significant when you're looking at mothers, expectant mothers. Proteins in the body, in the urine. Yes, great. Yes, in the preeclampsia moment. Okay, bilirubin should be less than 0.3. Ketones, they should be none. Remember, guys, they'll be present in DKA, diabetes ketoacidosis. Nitrates, none. Blood cells, none. Glucose, none. Remember, we'll be having glucosuria in diabetes mellitus, okay? Okay, guys, thank you so much. Yes, just a reminder that also for the proteins, we might have some proteins when you have taken excessive proteins, okay? And that explains when you are preparing for a clearance, creatinine clearance test, you check on your proteins so that we don't get false results, okay? False positive. Great. We have several waste products that we need to be aware of. One of it is ammonia, and this one normally originates from breakdown of amino acids in the liver. We have urea. This one normally results from the conversion of ammonia in the liver. CO2 from cellular respiration. Water, cellular respiration. Mineral salts, food and water. And lastly, lactic acid from anaerobic cellular respiration. Normal values also for blood urea. How to look at the blood, the level of blood urea as nitrogenous waste. The range is between 15 to 40 milligrams per deciliter. We also have serum creatinine, ranges from 0.6 to 1.2. Okay. Serum uric acid, we have 4 to 7. Sodium ions, we have 135 to 145 milliosmoles per liter. Potassium, we have 3.5 to 5.0. Chloride, 96 to 106. Bicarbonate, 23 to 27. Arterial blood pH, yes, it should range from 7.35 to 7.45. Okay. Arterial partial pressure of carbon dioxide, 35 to 45. What of oxygen? 80 to 100 millimeters of mercury. So guys, we have this important waste, and this is the creatinine. We're saying that this is normally a waste product of muscle breakdown, and the normal values, as we have indicated, range from 0.6 to 1.2 milligrams per deciliter. It is solely filtered from blood via glomerulus. It's not reabsorbed or secreted in the nephron. Thus, it provides the best measurement, okay, of kidney filtering. Okay, great. What about creatinine clearance? Amount of blood that the kidneys make per minute that is normally free of creatinine. It ranges based on gender and age, of course, so that we have females, adult females will range from 85 to 125 mils per minute, while males will have 95 to 140 mils per minute. So, these values should be interpreted with caution as they vary with age, gender, weight, and sometimes race. Glomerular filtration. Glomerular filtration rate, GFR, we say that the normal range is normally 90 mils per minute or higher. It represents the rate of blood flow through the kidneys, okay? So that we say decreased GFR will always lead to decreased urinary output, oliguria, and increased water retention. So this normally leads, when there is increased water retention, what result, guys? It leads to development of hypertension. We have issues to do with edema, electrolyte imbalance, and more waste accumulation in the body. So buildup of waste through blood, the one that we refer to as azotemia, yeah, normally results in metabolic acidosis. Which how hyperkalemia may result, okay, and you have increased phosphate. And when you have increased phosphate, you know it normally binds with calcium, so calcium reduces, okay. BNO, okay, blood urea nitrogen. We say that the normal range is 6 to 20 milligrams per deciliter, and it normally results from breakdown of protein in the liver, then secreted in blood and filtered in the kidneys. So increased dehydration normally contributes to BUN. Okay, thank you, guys. From the causes of acute kidney injury, we look at the stages of acute kidney injuries, and there are four. We have initiation, oliguric, diuresis, recovery. Let's go through the four stages, starting with initiation. Initiation, right from the word initiation, initiate is to start, okay? So that we're saying it starts from the cause, okay, to the kidney, and ends when the signs and symptoms appear, okay? From the cause to when the signs and symptoms are appearing, initiation. In terms of time duration, it normally takes few hours to several days. So treatment, you must find the cause. You must correct to prevent long-term damage to the nephron, because failure to correct this can result in chronic renal failure. Oliguric is the step 2. So some patients, we say that they skip this stage and they enter the next step, which is diuresis. Yeah, diuresis is the third stage. Okay, but you're saying that here the urine output is normally less than 400 mils per day. Remember, someone has to excrete 1 to 2 liters, but we only have here 400. Okay, and why is the person only able to excrete 400? It's because the glomerulus decrease ability to filter blood due to decreased GFR. Okay, so as a result, what happens? The BUN and the creatinine increase. And when this happens, when this waste accumulate in the body, they can lead to neuro changes, confusion, sleepy, itchiness. Okay, so what is the nursing intervention in this case, guys? A patient having neuro changes, having confusion, being sleepy, itchy, yeah? For the neuro changes, guys, we normally say you try to lower the protein diet, and you work on the safety of the patient because of those neuro changes and the confusion that results. Okay, so as a result of this, we have accumulation of several wastes. So the first one, which is very key for us, is hyperkalemia. Remember, the normal range for potassium is between 3.5 to 5.0. So if you have a hyperkalemia of greater than 5.1, okay, we say that this one is cause of decreased excretion of potassium. So potassium is not being excreted. So as a result, this one has significant changes, especially in the EKG. Okay, this patient is going to have tall peaked T waves. Okay, tall peaked T waves, wide QRS, prolonged PR intervals, which is an emergency to a nurse. So what is the nursing intervention for a patient in oliguric phase presenting with hyperkalemia? As a nurse, you need to restrict potassium containing foods like bananas. You need to monitor the EKG, okay, for these tall peaked T waves, wide PQRS, and prolonged PR intervals. We also need to look at the labs to ensure that the ranges is between 3.5 to 5.0. You administer kioxalate per oral. So the physician will prescribe kioxalate, and the nurse will administer this drug, okay, parectal or rectal, with an aim of reducing the level of potassium in the body. Another problem we said was increased fluid in the body. Okay, increased fluid in the body. Remember, you're only excreting less than 400. Okay, so we have increased fluid in the body. So this will result in edema, will have risk for pulmonary and cardiac issues, including hypertension. So what will be the nursing intervention in this case? As a nurse, you need to limit fluid intake. You need to restrict, okay, input and output, okay, so that you know how many in, how many out. You need to do daily weights, okay, monitor the blood pressure, lung sounds, saturation, oxygen saturation, look at the swelling in the case of edema, and institute measures that take care of the respiratory status monitoring and the safety of the patient, okay. Another problem that normally results from patients with oliguric phase, because of accumulation of those waste, normally leads to metabolic acidosis. So this one is due to the decreased pH. Remember the normal pH we talked of 7.35 to 7.45. So when there is metabolic acidosis, how the patient present? The patient will present with confusion. Patient will present with small breathing. This is deep, rapid breathing, and this normally helps so that it's a compensatory mechanism so that the patient is able to blow off carbon dioxide that is accumulating, yeah, in blood. Okay. What about mild hyponatremia? Mild hyponatremia also results from this. Okay, remember we have more fluid being retained. More fluid being retained, it means is going, and you know sodium loves water. So where there's that more water, less sodium, resulting in mild hyponatremia, low sodium levels. Okay. And partly this is because of the increased phosphate and calcium binding. Okay, it has been bind. We have also high urine specific gravity. Okay, it will be greater than this. So we have also oliguric stage, and this oliguric stage we normally say it normally lasts for a week to 2 weeks. A week to 2 weeks. Okay, so healthcare providers should ensure that this stage is short to minimize damage to the nephrons. So there is a likelihood of the patient undergoing dialysis in this stage, okay, so as to correct it. Let's go to the third stage, and the third stage is the diuresis stage. And diuresis stage here, we are saying here the nephrons are on their way to recovery, but they have not had their 100% recovery, okay? So they start to filter the blood, but not able to concentrate the urine. So GFR starts to improve, though we are saying it's still abnormal. So this one allows BUN and creatinine to decrease. Remember, in the oliguric phase, these levels had gone high, but here they start to decrease. So patient mental status will improve. Remember, in oliguric, the patient was presenting with neuro changes. So here the patient is improving, okay? So voiding, we say that we have 3 to 4 liters per day due to osmotic diuresis. So high amounts of urea are found in the newly filtered filtrate. And this is understandable because in the oliguric phase we had more wastes. Diuresis is recovering, so the more wastes are getting out of the body. So as a result, when you have more fluid getting out, when you have more fluid getting out, voiding out, you result in hypovolemia, dehydration, hypotension, hypokalemia, okay? And we'll have decreased urine specific gravity, okay? This process normally lasts for weeks to 3 weeks. As a nurse, what is your role? You need to have strict input and output. You need to check daily weights, okay? And also assess for the signs and symptoms of dehydration. Supplement intravenous fluids where possible. The last stage of acute renal failure is referred to as the recovery stage. From the word recovery, you're saying that it starts when a GFR returns to normal. Okay, urine output increases so that we have around 1 to 2 as the recommended one. Okay, BN levels, electrolytes, they start becoming normal. Okay, remember this stage, it can take a year depending on the amount of damage the patient had vis-a-vis the patient's age. Okay, we're saying that some patients never make it to this stage but develop CKD, chronic kidney disease. Okay, thank you guys. So here you can see the summary. Yeah, acute kidney injury, starting with the initiation, then going to oliguric phase, diuretic phase, and lastly recovery phase. So which one is the most tricky stage in all this? Yes. Which one is the worst stage? Oliguric phase. Very good, very good, very good. So in short, we can try to say that when you're trying to look at acute renal failure, we're saying that it's normally short in onset. Okay, it takes some days to weeks. Hemoglobin concentration remains normal. Renal size remains normal. Renal osteodystrophy is absent as opposed to chronic, where we'll be looking at it and we'll find that it's present, similar to peripheral neuropathy. And lastly, we have serum creatinine concentration. We normally have acute reversible increase. So it increases, then it starts going down. Okay? Thank you. We can go now to chronic kidney disease. So in chronic kidney disease,